Now it's time for our next session. This session will be on the updates in dermatology. The session will be taken by Professor Dr. Saumya Panda sir. He is the professor and head, Department of Dermatology, JIMS, Bhuj, Kolkata, India. He is also the emeritus editor of Indian Journal of Dermatology, Venereology, and Leprology. And the session will be chaired by Professor Dr. Shohidullah Sikdar sir, ex-chairman and pro-VC, BSMMU. He is also the president of Bangladesh Academy of Dermatology. I'd like to request our honorable speaker to start his presentation.
Thank you, everyone. Without wasting any more time, because already we are going very late, I shall start off with my presentation in right earnest. So, what are some of the more important thematic developments in dermatology? I have just basically sought to, so these are some of the more important thematic developments in dermatology that I have basically summarized my lecture into. The first thing is how to define dermatological diseases. Now, why I think it important is because there has been a great deal of movement in the age-old definition of some of the very common dermatological conditions and how we will have to look at those, how the future dermatology books will have to be written. And why is this important? Because it is fundamental. Because how we define a disease, on it depends how we manage it, how we prognosticate it. The next important thing is adipocytes in skin health. Now, these adipocytes we have ordinarily looked at as plainly as cells which are basically tasked with reserving our energy and fat. But recently, due to certain developments, these are being seen as very important in cutaneous inflammation, and these are basically seen as immune cells of very high order. The next is the role of microbiomes, dysbiosis, that is the change in the microbiomes in different diseases, and the gut-skin axis, that is how the microbiomes of the gut basically impinge on some inflammatory skin diseases, and the other way around also, how the microbiomes of the skin also basically impinge upon some systemic diseases. How we look at the skin barrier function and immunology, the evolving understanding of autoimmune mechanisms and what is new in the way we treat the autoimmune dermatosis, the development of the skin aging biomarkers, the very important conundrum of vitamin D and immunomodulation of skin. So whatever disease that we look at, whether it is psoriasis, whether it is vitiligo, whether it is atopic dermatitis, or whether it is, almost anything, alopecia areata, whenever there is a study, there is low vitamin D. But when you supplement vitamin D, supplementation of vitamin D is almost ubiquitous nowadays. In every disease, we are supplementing vitamin D. Unfortunately, we do not get any concomitant results. So this has been a great quandary, and a very recent study has come up which has sort of tried to address this quandary. Itraconazole and serum cortisol. This is also a very important snippet. We all know that itraconazole is our linchpin in steroid-modified tinea. So why so? There are other anti-fungals like laliconazole or even miconazole, which have greater, or I should say less, minimum inhibitory concentration. That is, higher degree of antifungal susceptibility is seen with those. But why itraconazole is so dramatically effective and these things are not? So we'll come to that. Advanced imaging techniques, personalized medicine and targeted therapy. A lot of talk has already gone on regarding that. The omics technologies. It has all started with genomics when the human genome map was defined for the first time. And together with it, the proteins have been delineated, the proteomics, the metabolic end products giving rise to the metabolomics, and the RNA mapping of the body has also been done, and different diseases also. That is known as transcriptomics. So what all those technologies will lead us into in the future, the nanoparticles and exosomes. And finally, the applications of artificial technology and virtual clinical trials. Possibly in 45 minutes, I would not be, now 40 minutes, I would not be able to do justice to every one of these, because just naming these things took me 5 minutes. So don't worry, wherever those 45 minutes will be over, I will stop, and I'll be there the whole time, and you can ask me any questions that you like later on. So first to come to the concept of progressive disease definition in dermatology, which I say is a novel conceptual framework, and all of you should know that. Now, why disease definition is important? Because it's a foundation on which all clinical practice and research rests. For example, all of you know about the UK diagnostic criteria of atopic dermatitis. I do not know how many of you have noted that if we apply the UK diagnostic criteria, or the so-called modified diagnostic criteria, I mean, it fits perfectly well with scabies. So this is a very important insight. So if somebody who uncritically applies the UK diagnostic criteria might, misclassify a perfect case of scabies into atopic dermatitis and treat like that, and that will be dangerous. So disease definition is very important. Now, what is progressive nosology? Progressive nosology or disease naming refers to the way in which dermatological conditions become reclassified as biomedical discoveries are made. Now, we all know that certain, our definitions or disease definitions, these are not so progressive. For example, say a condition called lupus miliaris disseminata fasciae. Now, it's a very good, morphological description. But does it give any kind of insight into the pathogenesis of the disease or how we manage the disease? No, unfortunately, no. And there are some of the things, which I'm sorry to say, just there to make us look important. For example, if a patient comes to us and says, sir, I have a long brown streak in my nail, and I would say, you have longitudinal melanonychia. The patient would say, okay, that's all very impressive, Dr. Panda, but what exactly is that? Then I have to say, you have a long brown streak in your nail. It doesn't mean anything. And basically like that. And for example, you take the case of patch stage mycosis fungoides. I have a great reservation to this diagnosis because the patch stage mycosis fungoides, there is no indication that it can evolve into plaque stage or a genuine case of mycosis fungoides, that is grade 3, if not treated, because it is not so very simple. And the treatment is topical steroids. So why don't you call it just as large plaque parasoriasis? It might cause much less concern among the patient. We have to think about all these things and should not tend to over-dramatize a condition or, seek greater glory for ourselves at the cost of a great degree of mental disturbance to the patient and their families. Then names such as acne excoriae or neurotic excoriations, these should be dropped as they invite judgments that might not be appropriate. And conditions such as atopic eczema. Now, I talked about the UK criteria, diagnostic criteria of atopic dermatitis. There are lots of criteria or diagnostic criteria of atopic dermatitis. Now, in any of these criteria, I mean the current definition of atopic dermatitis, or what is atopic dermatitis actually? Atopic dermatitis is nothing but the existence of specific Ig antibodies to some common environmental allergens. Now, is this fact drawn or is this fact represented by these diagnostic criteria? Unfortunately, no. That is much better represented by the filaggrin gene modifications. So we have to, that's what we mean by progressive nosology. So perhaps we need to revisit all the diagnostic criteria of atopic dermatitis. Now, we have to realize that skin diseases are not external entities that attack patients, but are the result of an interaction between biological, psychological, and social factors in individuals, right? And we have to be very cautious of the phenomenon of disease mongering, that is the selling of disease in order to grow markets. For example, this new classification, or it was not new, but it has certainly come up quite a bit in literature, the erythemotelangiectatic rosacea. Now, it's a moot question whether this erythemotelangi, we are seeing more reference of it in the literature after the marketing of the brimonidine gel. If you do not believe me, just go through the literature. So just look at from what time you get more of these references of erythemotelangiectatic rosacea in the Medline or PubMed and the date of the marketing or date of approval of brimonidine gel by US FDA. Then you will find the answer. So we have to be, in our disease definitions, we need to look forward or we need to be more progressive. We come to the role of adipocytes. Now, just about 10 years back, in the Cold Spring Harbor Perspectives in Medicine, Rivera Gonzalez and the team mentioned it, that the classic studies in the 1950s studying the death and the regrowth of the postnatal hair follicle noted that the dermal adipocyte layer dramatically changes its thickness in synchrony with the spontaneous regeneration of the hair follicle. And for the last 10 or 15 years, we know that it is the dermal adipocytes which are responsible for such common conditions, relatively common conditions as frontal fibrosing alopecia and even female pattern AGA, female pattern, androgenetic alopecia. Now, have in our management, did we try to address this? Unfortunately, no, but it will have to. We'll have to. How? Now, what is dermal adipose tissue? Now, all of us have a notion that the adipose tissue is there only in the subcutaneous fat. That is the fat layer. But we know for the last 10 or 15 years that is the dermis, just below the reticular dermis, there is a layer of dermal white adipose tissue. Now, it is not as predominant as subcutaneous white adipose tissue, which, by the way, is the largest organ in the human body, the subcutaneous white adipose tissue, right? And it differs a lot with the dermal white adipose tissue in that the dermal white adipose tissue is mainly done or mainly concerned with elaborating some pro-inflammatory and a few anti-inflammatory cytokines like adiponectin, right, in different conditions. And excess visceral white adipose tissue is metabolically unhealthy, while excess subcutaneous white adipose tissue can be protective against various metabolic diseases. And many of these metabolic diseases have connection with many inflammatory conditions like psoriasis, which is pretty well known, but there are many others too. Now, this is also a statement which we can make, and possibly, I do not know to how many of you it will come as a surprise, that obesity is a state of inflammation. That obesity does not only lead to states of inflammation or inflammatory diseases, but obesity per se, by itself, by and in itself, is a state of inflammation. Why? Lean adipose tissue is characterized by IL-10 and a Th2 cytokine profile that maintain a homeostatic environment predominated by M2 macrophages, regulatory T cells, eosinophils, and invariant natural killer T cells. When a person becomes obese, the adipose tissue is infiltrated by large amount of M1 macrophages, CD8 T cells. There is a transformation from Th2 to Th1 cellular makeup and neutrophils that lead to upregulation of tumor necrosis factor alpha, IL-1, IL-6, and other pro-inflammatory cytokines. Now, this TNF alpha, produced primarily by adipose tissue-associated M1 macrophages, impairs insulin sensitivity in adipocytes. And on the other hand, IL-17 produced by T cells and IL-18 produced by macrophages and potentially by adipocytes themselves downregulate the adipocyte genes associated with lipolysis and lipogenesis, fatty acid uptake, and adipokine production. Now, this gives an idea how important obesity is as an inflammatory condition by itself. And it is basically an immune disease. Now, why so? Because when there is excess body fat, there are changes in neutrophil, monocyte, and lymphocyte count, as well as lower T cell and B cell induced proliferation, leading to an overall decrease in immune function. And we can attribute immune dysfunction to be a major contribution to obesity-associated manifestations such as insulin resistance and inflammation. So what happens with an increase in the severity of obesity? The macrophage aggregates grow larger, exhibiting a similar pattern as seen in other inflammatory conditions. And this has led to the hypothesis that macrophage aggregates could be used as a measure of the inflammatory state in obesity, right? Now, what obesity does in very simple terms, by mechanical stretching, it impairs the skin barrier, and by the elaboration of certain cytokines called adipokines, and it basically sort of impinges upon the collagen structure by attacking the fibroblasts, and it also, by its effect on the sweat glands and sebaceous glands, it leads to the elaboration of certain other adipokines which causes microcirculatory disturbances. So this is how obesity, in short, can affect our system. Now, what are the adipokines? This is not a comprehensive list, but this sort of can give you basically an idea of the extent of what kind of all this is released or liberated from the adipocytes. So we can classify them as acute phase proteins, cytokines, and chemokines. A lot of them, basically. And then there are the adhesion molecules and extracellular material components and other factors. And finally, the factors directly affecting the metabolism, the so-called adipokines, but which ultimately impinges upon the inflammatory process too. So this is a model which describes in very short how the obesity influences cutaneous inflammation. The fatty acids, they attach to the CD36 receptor. They basically promote the innate immunity by elaborating the nuclear factor kappa B that elaborates the NLRP3 that leads to the formation of inflammasomes, leading to insulin resistance and cutaneous inflammation. So, what are the effects of adipocytes on inflammation in obesity? The macrophages produce pro-inflammatory cytokines, pro-inflammatory adipokines. Most of the cytokines released from the adipocytes are pro-inflammatory, as I have said, like leptin and resistin. And there are only a few, like adiponectin and omentin, which are anti-inflammatory. Those are downregulated. Now, cathelicidin, which is an antimicrobial peptide, this is basically elaborated, and it stimulates T-cell mediated immune response. And the fatty acids stimulate the Th17 differentiation and various downstream cytokines, right? So this is a relatively simpler model of how the adipose tissue or how obesity can lead to or aggravate atopic dermatitis and psoriasis. A hypertrophied adipose tissue gives rise to elaboration of subcutaneous and dermal white adipose tissue, leading to mechanical stress of the skin and restructuring, stretching of the epidermis, leading to barrier defect, and the free fatty acids, the leptins, and all the pro-inflammatory cytokines which basically are liberated from the adipocytes. These give to the release of more neutrophils, monocytes, and activated dendritic cells, giving rise to IL-1, IL-17, and sometimes IL-22, these pathways, which directly cause psoriasis. And the adipoq, that is the adiponectin, which is downregulated, this causes the downregulation of T regulatory cells, which are the anti-inflammatory T cells, giving rise to the activation of the Th2 and the elaboration of the IL-22 and IL-4/13 led acute allergic inflammation leading to atopic dermatitis. So this is again the same thing, adipokines, psoriasis, and increased cardiovascular risk. The adiponectin and omentin, these are anti-inflammatory. All the others like leptin, resistin, TNF-alpha, these are all pro-inflammatory cytokines elaborated from the adipocytes. They cause endothelial dysfunction, increased cardiovascular risk, which is so very prevalent in psoriasis. Now, what are the possible consequences due to altered adipokines in psoriasis? The adiponectin, which is downregulated, leads to development of vascular diseases and metabolic syndrome. And all the upregulated pro-inflammatory cytokines, that is leptin, resistin, visfatin, etc., causes the development of vascular diseases. And retinol binding protein 4, if upregulated, causes development of metabolic diseases like insulin resistance and type 2 diabetes. The omentin, which is an anti-inflammatory cytokine, if downregulated, leads to the same result. And TNF-alpha, obviously, and IL-6, you know, if they're upregulated, they cause also the development of vascular diseases and the development of insulin resistance. So these are the various adipokines, which are, for example, this gives a summary. For example, the adiponectin, this is released from the keratinocytes. They stimulate the fibroblasts, and they are also released and stimulated by various events in the sebocytes, and they also stimulate certain cytokines from melanocytes, right? So this is basically gives a summary of the relative effects of the various adipokines. Now, there is another kind of adipose tissue, that is the brown adipose tissue. For a long time, the idea was the brown adipose tissue is only, seen in neonates. But now, we have enough kind of evidence to see that brown adipose tissue is also there in adults. And more importantly, brown adipose tissue can basically nullify the ill effects of the various kinds of obesity and white adipose tissue, because brown adipose tissue is associated with thermogenesis. That is, the kind of energy that is stored in the adipose tissue will not lead to obesity, but will lead to excess calorie production in terms of heat. So it may be possible to generate human-induced pluripotent stem cells from patient-derived somatic cells that are reprogrammed to have a thermogenic adipocyte fat when transplanted into recipients. And chemical and hormonal induction protocols to generate such cells have not yet been described, but would be of interest. Directly transplanting patient-derived brown adipocytes into obese individuals to improve metabolism may also be possible and has been demonstrated in rodent models. And it is something which will be of interest in the near future. Now, these are some of the dietary components which will be interesting to know might lead to loss of obesity in the sense that they promote the production of thermogenic potential, that is promotion of brown adipose tissue. Among these are tea, curcumin, that is holud, capsaicin, lonka, which are common ingredients of our dietary system, and all these are eicosapentaenoic acid, ginger. So all this is good in a sense, in simpler terms, in combating adipocyte-induced metabolic and inflammatory conditions. Now, so there is a concept called reactive adipogenesis. Now, what is reactive adipogenesis? When there is Staph aureus-induced inflammation, the adipocyte, they are stimulated, and they basically tend to produce greater amount of cathelicidin. Now, this cathelicidin is a hallmark of inducible antimicrobial peptides. We have two kinds of antimicrobial peptides. One is constitutive antimicrobial peptides, that is there, like beta-defensins and RNase 7. And cathelicidin is a kind of antimicrobial peptide that is there only when it is induced by some inflammatory process like Staph aureus elaboration. For example, and it is elaborated by everyone, by the sebaceous gland, sweat gland, everything. So here we see the relation between adipogenesis and our human microbiome, about which we'll speak in very brief. Well, how important the microbiome is. The approximation of skin surface area of our skin surface area is commonly known as 2 square meters, right? But it is a gross underestimation because this does not take into account the pilosebaceous units and sweat glands. Together with its appendages, the skin accounts for 25 to 30 square meters of surface area for an average adult, making it one of the largest interactive surfaces for the human body. Now, this surface is home to numerous phyla, 19 phyla to be exact, and species of resident microbial population consisting of bacteria, fungi, viruses, protists, and archaea. What is the number? Staggering count of around 10 to the power 12 microorganisms are estimated to inhabit the environmental niche and compose the microbiome of the skin. And there are certain studies that demonstrate a high density of 10 to the power 7 microbiota per square centimeter, putting the number of microbiota at a staggering 3 trillion. Right? Now, this is the last, is the whatever in the italics is the comment of the Human Genome Project paper, that the bacteria of the human microbiome are numerically superior compared to the human cell, and their genetic heritage is clearly superior to the human genome. মানে বেসিক্যালি আমরা এই যে বডিতে আমরা বাস করছি, এটা আমরা ব্যাকটেরিয়াদের কাছ থেকে ভাড়া পেয়েছি, এবং ব্যাকটেরিয়াদের যে জেনেটিক হেরিটেজ সেটা অনেক সুপিরিয়ার আমাদের থেকে। সো বেটার উই শুড বি, সেটা আমাদের ব্যবহারেই অবশ্য বোঝা যাচ্ছে দিনকে দিন যে আমাদের সঙ্গে ব্যাকটেরিয়ার হয়তো খুব একটা কিছু তফাৎ নেই, এবং ইনফ্যাক্ট দ্যাট ব্যাকটেরিয়া ইজ সুপিরিয়ার, দ্যাট ইজ দ্য বায়োলজিক্যাল প্রুফ। Now, what are the spectrum of microbiota? Actinobacteria and Firmicutes. What are Firmicutes? Staph and Strepto. These are the commonest, followed by Proteobacteria and Bacteroidetes. Now, actinobacteria comprise approximately half of the bacteria on the skin, with Cutibacterium, which was previously known as Propionibacterium, and Corynebacterium making up the majority of this population. Cutibacteria can become pathogenic during favorable conditions when certain phenotypes are present, notably leading to the development of acne. An increased population of Corynebacterium is seen in psoriatic lesions and ulcers, including infectious strains compared to healthy individuals. And non-pathogenic staph strains were found in elevated levels on the surface of the skin in adolescents with atopic dermatitis. In addition to bacteria, the skin microbiome also harbors fungal organisms, with Malassezia species being the most dominant. So this is how the microbiota changes in our body with age in the newborn, and that is also dependent whether it's a cesarean delivery or a vaginal delivery, but mostly it is the Firmicutes which are commonest. So that's why we know why certain bacterial infections are common in children, like pyoderma, like impetigo, right? And gradually with age, these Firmicutes, they become less, and the actinobacteria, they become more. So this gives us an idea. Now, the microbiota helps the establishment of immunological tolerance. Now, this Vitracilla and the staph epidermidis, both of these give rise to certain cytokines called CTLA4 and ICOS-14, which gives rise to immune tolerance. And they also basically give or elaborate or stimulate the T regulatory cells, which are responsible for maintaining a homeostasis in our immune system. Both the FOXP3 positive, which is stimulated by staph epidermidis being a commensal organism, unlike Staph aureus, and Vitracilla, which gives rise to the FOXP3 negative Treg cells. Now, what is the gut-skin axis? It describes the relationship where the gut can influence skin health due to its immunological and metabolic properties. 500 to 1,000 bacterial species inhabit the human adult intestine. Now, there are certain examples. The relative abundance of one species, Ruminococcus bicirculans, was decreased in patients with alopecia areata relative to that in their sibling controls. And that's why we know that in alopecia areata, particularly those alopecia areata where the gastrointestinal disturbance is very prominent, that is basically, that has a worse prognosis. That we have known for long, but we did not know its cause. The cause is this. Interestingly, recent mouse models suggest that the skin microbiome may also have an impact on the severity of inflammatory bowel disease, as Malassezia restricta, a common commensal of the skin microbiota, was found to be associated with Crohn's disease and correlated with increased disease severity and exacerbation of ulcerative colitis. So the gut-skin axis is not a unidirectional flow. Both the skin microbiota can influence the gut, and the gut microbiota can influence the skin. So these are the gut microbiome during life, which can influence the inflammatory disease processes in the skin. And this is also a relatively simpler model of how the gut microbiota can cause atopic dermatitis by basically promoting the where the profilagrine, which is dissolved into filagrine monomers, they basically get broken down to histidine and arginine. And the histidine, in response to the ultraviolet rays, because the barrier function is destabilized, this give rise to histidine metabolic pathway, they give rise to ammonia, the increase in the skin pH, leading to the elaboration of pro-inflammatory mediators from keratinocytes, and the S. aureus, Staph aureus infection pathway is also stimulated that way. Now, why are over 90% of our atopic dermatitis patients colonized with Staph aureus? So in normal skin, microorganisms are recognized by innate immune receptors such as toll-like receptors on the keratinocyte surface, and keratinocytes produce antimicrobial molecules such as human beta defensin 2, human beta defensin 3, nitric oxide, etc. And IL-8, which is a neutrophil chemokine, is also produced to derive neutrophils from the bone marrow pool into inflamed skin. In a Th2 environment, IL-14 and IL-13 induce the phosphorylation of STAT6, which inhibits gamma interferon and TNF-alpha. This, in turn, inhibits the production of human beta defensin 2 and beta defensin 3, causes a reduction in the production of IL-8, and results in defective neutrophil accumulation in the skin, right? So this is why the atopic dermatitis patients are colonized frequently with Staph aureus. So the skin commensal infections, interactions with Staph aureus, one can see here, basically, due to lack of time, I won't deal with this, but you have to know there are certain commensal organisms like Staphylococcus lugdunensis, which produces an antibiotic called lugdunin, which inhibits Staph aureus. Staphylococcus hominis, which produces a group of antibiotics called lantibiotics, which also inhibit Staph aureus. And the Staph epidermidis, by the serine protease pathway, it basically inhibits the biofilm formation. And the Propionibacterium acnes, very interestingly, by producing some small molecule coproporphyrin 3, it inhibits the Staph aureus, right? So what are the therapeutic modalities targeting microbiome? Prebiotics, probiotics, bacteriophages, and transplantation. Fetal microbiota transplant, you might have heard. So these are the probiotics and prebiotics which are basically commonly used or commonly seen in the preparations, and most of us are using these. But just see the kind of diseases: acne, psoriasis, photoaging, atopic dermatitis, allergic contact dermatitis, even wound healing. All these can be basically impacted by the use of these prebiotics and probiotics. So they have a genuine evidence in favor of their use. So what are the topical probiotics? Now in atopic dermatitis, Staphylococcus thermophilus, V. filiformis, what we spoke about earlier, Staph hominis, Staph epidermidis, L. johnsoni. And there are preparations which are experimentally available, but these are not being marketed as yet. In acne, L. plantarum and cell-free supernatant from Enterococcus faecalis, these have been found to be effective. In reactive skin, Bacillus longum extract has been found to be useful. In elderly skin, to reduce the xerosis, S. thermophilus has been found to be useful. And in psoriasis, the ethanol extract of L. sakei. So in the next 10 years, maybe, we can see more of these topical probiotics coming into picture and getting into clinical use. So this is how the bacteriophages are used as topical treatment. The sample skin is collected. The disease or health-associated microbes are isolated. The phage targeting the species of interest is collected from this sample. The phage is isolated, targeting only the disease-associated microbes. It is confirmed as health-promoting phenotype by the different tests. These phage and health-associated microbes are then combined and applied as topical treatment. All this is in the realm of experiment right now, but all these are probably going to be in our armamentarium in 5 to 10 years. Now, these are the composition of the human fungi microbiota in various locations. Now, this gives rise to our interesting phenomenon or explanation why itraconazole is so dramatically, successful against steroid-modified tinea. In a very recent study, it has been seen that 1 month of oral 100 mg itraconazole every day reduces the morning plasma cortisol levels by approximately 37%. And itraconazole is a triazole. This is how. It basically inhibits two important enzymes, 21 alpha hydroxylase and 11 beta hydroxylase, which are responsible for the conversion of 17 alpha hydroxyprogesterone to 11 deoxycortisol and 11 deoxycortisol to cortisol respectively. So this is perhaps the reason why itraconazole is so very dramatically effective in steroid-modified tinea. This is a very recent report done by, the work was done by some Bulgarian investigators. Now this is another very interesting thing, why some of us get so very disappointed with the biologics. Now with the biologics, the response is almost immediate, but it does not influence the relapse of the conditions, any condition, whether it is atopic dermatitis by dupilumab, whether it is psoriasis by so many biologics, whether it is vitiligo, or you name any condition, because the problem is we are targeting only the active cytokines which are present there during the inflammatory process. But there are certain factors and certain cells and certain cytokines which remain dormant as memory. And these we are not targeting at all. There are recent work on these, and possibly this is going to be the next frontier. That is the effector functions of tissue-resident memory cells on the pathology of skin diseases. For example, psoriasis is mediated by IL-17 positive and IL-22 positive tissue-resident memory cells which trigger inflammation. These remain dormant, right? So both CD49A positive and 49A negative, 103 positive, and CD8 positive tissue resident memory cells accumulate in the psoriatic areas. In particular, CD49A positive 49A negative, CD103, and CD8 positive tissue resident memory cells are the major producers of pro-inflammatory IL-17A. In contrast, the CD49A positive, 103 positive, and 8 positive tissue resident memory cells have potent cytotoxic functions in the secretion of perforin 1 and granzyme B. Similar to CD8 positive tissue resident memory cells, keen CD4 positive tissue resident memory cells play a role in the relapse of psoriasis in humans. IL-22 produced by CD4 positive tissue resident memory cells affects the survival, proliferation, and differentiation of keratinocytes by producing antimicrobial proteins and chemokines. But this does not work the same way in every disease. In vitiligo, for example, it is triggered by CD8 positive T cells that abnormally target melanocytes for elimination. The production of CXCR3, that is chemokine ligands mediated by gamma interferon secretion, is essential for the recruitment of autoreactive CD8 positive T cells in vitiligo in animal models and humans, and is associated with development and severity of the disease. JAK inhibitors block interferon signaling, resulting in the reversal of the disease state, while treatment with these inhibitors appear to have no effect on the number of tissue resident memory cells. So perhaps the next what we are going to hear are targeted agents against tissue resident memory cells and these various cytokines. And this might give us a great breakthrough in preventing the relapse of psoriasis, vitiligo, and other conditions. So I have already crossed my time limit. So a lot of things I cannot just cover, but there is always a next time. Lots of references and everything. So if any of you want to discuss, I'm here the whole day. Thank you very much, and thanks to organizers.